Hi there, and welcome to Objectivity's Value-Based Population Health Analytics webinar. This is going to be really exciting. We have got some extraordinary people taking part in this show today. We have Philip Anderson, all the way from Harvard and from Brigham over in Boston. Hi, Philip.
Hi, Peter. Good to see you. Good to be with all of you here today.
It's great fun. And we have Thomas here from Sweden, who's been implementing a lot of the technology, who's CEO of HVAB.
Yes, thank you.
And we have Marcus here as well, who is in it for real. I mean, you're actually doing it with real patients. So it's gentlemen. Actually, I'm going to bow out here for a little while, and I'll let the three of you take the lead here, because I think people are here to hear you, and I don't think they're here to hear me. So so I'm going to bow out for a little while.
So thanks for having us, Peter, as said. So quick background. We are three people here. Philip will tell us a bit about the background, where we're coming from, and why this platform is a great way to work and this process. Marcus, head of strategy for Region Halland, will tell us about how it's actually done in real life. And I will try to tell a bit about the solution. But should we give a quick background? Philip, who are you?
Great. Well, yeah, thanks. Yeah, good morning. Thanks, Thomas, and good morning or good afternoon, everyone. My name is Philip Anderson. I'm an emergency medicine specialist by training. I've worked for the past 2.5 decades or so in academic emergency medicine, but have also led our efforts working with healthcare systems in multiple countries to work with optimizing and improving care delivery. And we've worked extensively with colleagues in Sweden in the Swedish regional healthcare system network to develop a lot of the ideas that we're going to be talking with you here about today. So real pleasure to talk with you, Marcus.
Thank you, Philip. Thank you for having me. I'm Marcus. I'm a cardiologist by training. I work in a hospital group within a region in the on the western side of Sweden, where we try to act like a healthcare system that is not too fragmented. We try to work fact-based and information-driven, and I have the opportunity to do that in my managerial position. So the latest 10 years, I've been more and more into management, and for the last 5 or 6 years, we've been working with Philip and his team to develop the methods and also deploy the methods that we are now using in order to create efficiency and patient safety and all other sought after outcomes that we have in healthcare. So, but I will return to a few of those later on. Thank you.
And as said, I'm Thomas Davidson. I'm heading up this company running the platform Sharpec. I'm an economist by training. I worked extensively with financial control and IT, and that happens to be a good combination together with Philip and Marcus and his team. So we have a few slides. We will be fairly quick, so but please interrupt if you have questions, and Peter or Matthew, please guide us. But Philip, I'll let you go. Please get started.
Great. No, thanks very much, Thomas. So, folks, the story that we want to talk to you about here today is about what Region Halland has been able to accomplish. In a few short years, they've been able to save both about 10 million euros annually in terms of their overall operating budget, which is about 2% of their overall healthcare spending. And they've also been able to become one of the highest performing regional healthcare systems in Sweden, both in terms of quality and population health. And the way that they did this was by using their data in smarter ways to implement new processes that they could have greater confidence would improve outcomes and lower cost, as well as to create more data transparency. And they were also able to harness the power of AI and big data to deliver predictive modeling and more precise care for their patients. So, this whole story is really about international collaboration and what we can accomplish together. But it's also about, how we can really tap into big data and healthcare to tackle a lot of the stubborn problems that we've all been struggling with for decades. Next slide. So just want to say a couple of things about some of the background issues. And I think, these are I think are going to be familiar for many of you, but as we all know, healthcare globally is facing a number of really kind of existential challenges, mainly about sustainability, I think. We have aging populations that are living longer with, more chronic conditions that increases the utilization and the demand for acute care services and leads to rising budgets. There's also a greater demand, from the public for new diagnostics and other treatments, and and an expectation to really continuously improve outcomes and reduce cost. A big set of challenges really to try to tackle. Number two, can you next slide? Yeah, and I think one of the main things that complicates our ability to make progress on that sustainability front has to do with some of the fundamental structural characteristics of how healthcare is organized. There's a lot of fragmentation, as we all know, around the specialty silos of care delivery, the different sectors of care delivery, and that creates challenges in terms of being able to both understand and to implement solutions that improve care at the population level, where populations of patients, they receive care across all of those silos of care delivery. But the way the system is organized and managed is more around the silos of care delivery and less around the patients that they serve. Now, globally, there's been a trend to move towards accountable care organizations, which are more of an integrated approach to managing this. And I think that we see that as one of the strategies for how to try to do that. The other big challenge I think that we face, or maybe it's a lost opportunity, is the fact that we are seeing this explosive growth in all different types and the quantity of electronic health data, and yet our ability and ways of being able to use that, I think thus far has been limited. And I think what we really want to try to address is how can we do a better job of using that and tapping into that tremendous potential for insights for developing our systems. Next slide. So in Martin Engstrom, the regional director, the CEO of the healthcare system in Region Holland, he talks very eloquently about their journey of adopting more information-driven care, and how by doing so, really embracing data, that gave them courage to make difficult decisions and the power to drive many new change initiatives. And in order for healthcare systems to go down this pathway of really taking advantage of that power that Martin talks about, it's not simply a question of just implementing a new EHR system or some other electronic data system. It really requires that organizations fundamentally change the way that they work with data to be able to really take advantage of the full impact. And I think some of the areas in which that kind of transformation to really more fully use data are things like having better accountability that's informed by data transparency, to do strategic planning based on quantitative modeling and quantitative insights, and then also just to be able to use data more in real time, to support operational decision making at all different levels in the organization. Next slide.
So that's me quickly. So today we'll talk a lot about ACOs, or healthcare organization providers, but one big and important customer group for us is the big pharma. where we see quite a pickup. And the reason for that is that with this approach, we can combine the clinical data, but also resource data, cost data, which really means that we can measure care consumption in pounds or dollars or euros in the actual ACOs, in the actual healthcare organization. i.e., we measure their own costs with their own data, not health economics or national standards. Philip, back to you.
Sure. Yeah. So, the work, our team from Boston here at Brigham, we worked really closely together with Marcus and his team at Region Holland in a multidisciplinary, multi-year collaboration where we were focused on developing new tools and new methods for optimizing care delivery, and that was really the beginning, I think, of this journey towards more information-driven care, and led to the development of the platform that we're sharing with you here today, the Sharpic platform, which is a software tool for being able to carry out these kinds of analyses that support decision making and improved clinical care. And I think one of the key points that we've learned is that the success of this, I think, has really been driven by the fact that at every step of the way, we've had clinicians involved in thinking about both defining what are the pressing problems that need to be solved, what are the important decisions that need to be made from a clinical and operational perspective, but then also to frame those analyses in a way that really address those questions from a perspective that can really that's actionable, for clinicians and decision makers. So I think we've really approached this from the notion of this being by clinicians for clinicians, in terms of how we try to address and solve problems. And so as we move forward and are implementing this, we're our team here in Boston is working hand in hand with Hollandia to both continue to develop the platform, but also to implement that in a way that will allow regions and healthcare systems to be successful. Next slide.
Right.
Thomas, I think that's you. Yep.
Yeah, thanks. So how did we do this then? Well, we were allowed to think big and free when we had clinicians on board from start. So I just want to re-emphasize what Philip says. This is by clinician for clinician, although myself, I'm being an economist and like financial control. But that allowed us to think about it as a manufacturing process without making that sensitive. So the basis for what we're doing is really a patient trajectory focused approach. So the patient's journey throughout the system is the focus. We think about it very much as a manufacturing process. And that means that we need to take control not only of clinical data, which is of course important, but quality and cost. We need to be able to manage all aspects of a healthcare organization, or, as I said previously, to really understand the complete picture for a pharma company making a treatment for a specific diagnosis or medication. So the model we have behind this combines clinical data, all cost data, and all resource data. That means really that we can think about it very much in the same way as a manufacturing plant to optimize it. And of course, the patient outcome is the number one priority, and that should never, ever be negotiated. But it helps enormously to think about it in this terms for planning purposes, or really understand the cost structure. The way we do it is to send in patient data, cost data, capacity providers here. That's sometimes a US term, but in the UK and the rest of Europe, doctors and nurses, all the encounters and the clinical data. That really allows us to do two specific things. One is the healthcare management for ACOs or healthcare organization, where we can do variance analysis or return on investments, etc. And on the other leg, we then do personalized precision medicine. What that means that we do what this is really much more about the media and the kind of exciting stuff. We can do prediction for specific individuals. We can do risk groups definition. We can do cost analysis, and of course the whole set of machine learning and AI predictions. So that's a platform in a nutshell. Marcus, so what have you done with this?
Lots of things. Thanks, Thomas. We are very much in Holland like an accountable care organization. We cover a catchment area of 300,000 people. And we, like the rest of Western healthcare, we're facing challenges in terms of demographic transition-driven increasing demand for acute care, and with that comes rising costs. And this is not anything particular to our county or country. This is what we see everywhere in healthcare. We have to deliver this care. We have 3 acute care hospitals. We have 50 primary care centers, and we have also 6 municipalities connected with us. So we're covering the whole care chain, so to speak. And before we had these tools, our healthcare was not only fragmented in terms of organization, it was also fragmented in terms of data silos and data domains. So like financial data was in one place or several places even. Clinical data was in another place or several other places, and the patterns could not be seen that clearly. So, and the slideshow disappeared to me, but maybe we can turn to the next slide now. So what we did was, and returning now to the first slide shown by Philip, to gather all the data and looking at the whole healthcare system from all angles simultaneously. So we could, and we can now follow the patient trajectories across the whole care chain to understand what happens, for example, if we intervene in one part of the care chain, say primary care, what happens with costs in the really cost-driving part of the care chain, which is in-hospital care. And working systematically across those healthcare chains from all perspectives simultaneously, we were able to reduce cost by 2% during a period of time where our population increased by 4.5%. So, and that placed us in the very comfortable upper right corner of the efficiency graph on your right. Next slide, please. And what do you do to get up there? Well, you need to be able to evaluate different ideas in relation to other ideas. And there is no lack of ideas in the system. We all have ideas about how to improve our healthcare chain, how to improve outcome, how to reduce costs. There are so many ideas, but where do you put your effort? And this is really challenging to on the management level, where I'm spending my hours nowadays, because you don't have bandwidth to invest in everything at the same time. And by investing, I mean either money or your effort. So by being able to simulate outcomes and simulate costs, and also doing this across the whole care chain on a systems level, but also on the individual level, the raw data is the same. You can relate all the ideas to all other ideas, and then you can evaluate and decide what's more important and what you should go for. So, and we can go to the next slide. One of those initiatives was on strokes. So I don't know if you have clinical backgrounds, but for those of you who are not that familiar with stroke, it's when a embolus from your blood usually gets stuck in your brain, and part of your brain dies. So what you do to prevent this from happening is to prescribe anti-coagulating pharmaceuticals. And you do that based on a risk score. So if you have a high enough risk for stroke, then you should be prescribed this medication. But this risk score consists of a number of different variables. And those pieces of information are usually, as data often is in healthcare, fragmented. They're stored in different parts of the healthcare system. And what we did was to calculate the individual risk score for all individuals in Halland with atrial fibrillation, because that's when you're supposed to have the heart arrhythmia disease. That's when you need to be protected from stroke. And we could realize that a number of the people living in our catchment area were at risk, but not prescribed adequate preventive treatment. So we monitored our whole catchment area based on this, and initiated intervention on the individual level, so that everyone was offered the right medication. And this is only doable if you can see your whole care chain and all pieces of information at once. And by this, we could prevent 70 strokes from happening, and as a benefit, we could also save a substantial amount of money, even if that was not the primary goal. So next slide, please. And what we also were able to do, but we thought of it early on, actually, a bit lucky, was that we could apply AI and on this data. And why is this interesting? Well, because the AI toolbox was actually built to see patterns in complex amounts of data. And it was also built to predict things. And that's what we do in healthcare, in clinical healthcare and in healthcare management. We need to see patterns in you as a person, and what, based on that pattern, what will happen with you in terms of adverse events, diseases turning up, etc. And that's also what you can use those data warehouses for on the systems level, predicting and identifying patterns where your patients are moving. And one example of this was that we could predict mental illness 1 year ahead of the patient actually turning up in our psychiatry clinic. And this helps us addressing the interventions more upfront, more earlier on in disease progression, in order to prevent things from happening. And there are a number of other AI applications that we developed and deployed in Halland based on these huge amounts of data that exist everywhere in healthcare. Next slide, please. So two other very short examples have been published in academic papers. The first one being able to identify who is actually at risk of dying within 30 days after they were discharged from the emergency department. So these are serious matters, but that's what this is what we're dealing with every day in our healthcare system, and that data was based on the data from 88,000 patients in our emergency department, and based on that data, we deployed and applied neural networks and 5 other AI models, 5 other algorithms, and we're able to show the power of AI in this this perspective. Another very operational example is that we are now able to predict who among all patients that are discharged from a hospital ward will be readmitted within 30 days as means of supporting our planning, our discharge planning, in order to make the future, the time after a hospital stay better and safer for the patients. And there are a number of other examples on this slide. So next slide, please.
So the thanks, Marcus. This is, I mean, I think it's really exciting to hear about how these analytic tools are being applied in improving care in Region Holland. The next steps for where we want to go with this are really looking towards how can we scale the development and the implementation of these this approach to using big data to better understand and improve how healthcare delivery works, but also to develop AI algorithms on a much larger scale. And so to that end, we are really delighted to be working with Region Holland and also with Halmstad University and a number of other partners in building what's been described as a healthcare data factory, where multiple regions, healthcare regions, will collaborate to allow their data to be analyzed in a way that is GDPR compliant and safe for protecting the integrity of individual patient data, and to be able to use that to develop a whole range of new algorithms for predicting healthcare outcomes of interest, but also to be able to do other kinds of analytic work, including benchmarking against national and international performance metrics, and also doing the kinds of real-world evidence analyses that Thomas was talking about before. So really, and this work is actually already started, and we're very excited about the coming year, where we hope that this will and expect that this is going to really start to grow and flourish. Next slide. So so just to summarize, I think we've tried here today to give you a quick snapshot of this use case in Region Holland, to really highlight some of the successes that we've seen there, that we think can be a model for how other healthcare systems can also harness their data to provide better care. And we think that really, for care delivery systems to succeed as accountable care organizations, it really requires that you have to have a data model and an approach to analytics that's based on the taking a whole system approach, as Thomas was describing before, where you have to get your arms around all of the data for the whole population and all of the production in the system. And once you understand this too, I think it's also what we've seen and Marcus has talked about is the idea that you really have to transform the organization in terms of how its ability to use that information and really integrate that decision into its decision making, and to be able to have mechanisms for really rolling out those analyses. And I think perhaps the most exciting thing about all this is the fact that there's so much hype about about applied AI in healthcare. But I think that Region Holland is one of the places where this is really being implemented, and it's not just hype. They're actively using this to really improve quality of care for their patients. So really a lot of exciting things that are happening with this, and want to I think close now, and we're happy to take questions, but really want to thank all of you for taking the time to come here today, and thanks Peter for organizing all of this. I think you're on mute, Peter.
One day I'll learn these things. There you go. Cool. I think this is quite an extraordinary thing, and like climate change, is it something that needs to be done urgently, or how do you see this being driven?
I mean, you mentioned climate change. I mean, that's certainly one of the greater existential threats that are facing the planet. I think I don't know if healthcare is quite the same, but I think there is an incredible urgency to figuring out how do we fix healthcare delivery kind of at a global scale. I mean, I think the urgency here is, if you look at the trends in cost growth, for healthcare spending, and you extend those curves out, they're simply not sustainable. There's a limit to the percent of a country's gross national product that can be spent on healthcare before you start crowding out other important spending priorities. And I think in the U.S. we're sort of reaching that point, if we've not reached it already. And I think so. It's particularly important, I think, here. But I think these are trends that everyone faces around the world. So I would say this is a crisis that we need to address seriously, and I'm hopeful that this approach that we've been focusing on here is a new way really of trying to address many of these fundamental thorny challenges that have faced healthcare for decades, by really using data in a much more extensive and way. But Marcus, Thomas?
Well, no matter what board members in healthcare systems say in public, we are very much aware of what is going on. So the demographic transition is putting a lot of pressure on healthcare systems today, and the increasing demand that comes with that, and also the medical development, the technological development in healthcare is providing a lot of solutions that are very good. They are sometimes regarded as being expensive, but we want to embrace those new techniques, new pharmaceuticals, new diagnostics. And how do we do these things all at once, meeting the demands increasing on the one hand, and internalizing all those new very valuable tools at the same time. And this equation is actually, without doing operations in healthcare in a completely new way, just not doable. You cannot continue delivering care the way you used to if you want to be in the business in 10 years or 15 years. So there is and the situation was very stressful, and that's actually why we started this journey in Halland. We wanted to get out of the corner that we were put into by factors pushing us into the corner, and now we're out from the corner, and it's a much better place, I can tell you.
Wow. I brought in Matt here because Matt's been receiving a number of emails here with a whole bunch of questions. But just before Matt comes in with his questions, I'd like to share with you from Christopher Holmberg from Sweden. We have a question here, Marcus, which I think, well, this might be Thomas, this might be Marcus. You can see the question here.
Yeah. Marcus, do you want to take it?
Yeah, sure. So how we got access to all these data sources? Well, actually, we own the data, so it's not that difficult as many people think it is, and it's not, and not even from a legal perspective. If you are one caregiver, at least in Sweden, I guess by the name that the question is from Sweden. You can do very much with your data as long as you are in legal terms a caregiver, a care provider, so having access to your own data was not that difficult. It was, however, a year of work to actually have the IT department doing the putting together work, like building the platform, structuring the data in a way that was useful, also for applying AI, building the patient encounter costing model, and we can return to that issue. Getting access, if you're a care provider, that part is not very difficult. We had a legal expertise with us every single step of the way in order to feel comfortable, actually. But they were very helpful, telling us that you can do this, you can take another step here, and you really need access to those kind of good legal experts, and not the naysaying ones, not the ones that say everything is dangerous, because it's not. The boundaries might be unclear, but if you're a well-trained legal expert, they're not that unclear, and the opportunities are much bigger than you think at first.
But also, quickly to add, we also have a great cooperation with, as an external partner with Region Halland and other regions where, we can do industry-sponsored research. So it's rightly applied approach techniques, clinical data as well as cost data is absolutely possible to work with. But you need to go through the proper steps. But we don't find that challenging, I have to say, in Sweden right now.
Can I just add one? Can I just add one point about this, because I think it's such a common question, such a concern, and I think what's really important to stress is the idea that Marcus said, that the data that we're talking about here, it all belongs to the healthcare system itself, and the platform that we've developed, that gets installed within the firewall of that healthcare system. So all of the data is retained inside of the system. So the healthcare region, they retain control of their own data. They retain the responsibility of protecting that data. But data is not being transferred outside of the region to a third party for the purposes of carrying out these things. Where the region is using the platform to do their own analytics with their own data inside of their own system. So I think that's why I think. One of the reasons why I think this is very safe from a legal perspective.
Does that mean, Philip, that the system will remain on premise, and that there won't be kind of, say, a cloud solution, for example?
Well, that's a really interesting and important question. I think the answer to that really depends on the local legal and political landscape, to be honest, because I think both options are absolutely possible, but I think what's most important is that this has to be these solutions have to have the trust and confidence of the public, right? Because this is healthcare data and healthcare delivery is something that is just so important for for populations, and so they have to trust this. They have to trust that this is being done in a way that they're comfortable with. And so whether it's on-prem or in the cloud, I think it just depends on what the local circumstances are comfortable with.
And in terms of because data is everything. So if I came to you and said, this sounds like a fantastic initiative, I'd love to integrate this into my business or organization. What kind of is there a minimum set of data that I need, or is it a case of you'll work with the data that I have, and do the results or the outcomes become more accurate or comprehensive with more data? How does that work?
Who wants to take it? Well,
you want to take that?
I can start.
Yeah.
So there are different levels here, certainly. But if you implemented, if you're a cluster of 5 primary care units, you still have a great value of understanding and co-working around your data. If you're a healthcare system like ours, including hospitals, primary care units, ambulatory care, and all parts of the healthcare chain, then you can do more things. And if you scale it up, so if you're a large region like say Boston, then opportunities are even greater, because then when you turn to AI, AI is very data hungry. So that's why you would like to, if you're a bit smaller or medium sized like us, you want to collaborate with others through sharing data if possible, but that's often not possible. And then there are other techniques to create value from data without actually moving any data. So like federated learning and other similar techniques. So it all depends on where on the scale you are, but understanding your costs in relation to understanding your outcome, that's universal. That goes for everyone, and I would say that every doctor should and needs to be interested in those relations, because that's how you manage your investments in relation to your product, which is health and longevity. And we work in Holland on all parts of this scale at once. We analyze small parts of our healthcare system with the tools needed for that, and also the whole healthcare system with the tools available for the system-wide analytics.
And Marcus, maybe it's an unfair question for you, but someone comments here about the replicability of outcomes across different regions and perhaps globally. Does the data take care of that, or is it a bigger consideration?
So replicability is interesting in some perspectives, but not others. So the first interest is to understand your own data, and that's a huge leap for many healthcare organizations, I tell you. But when you you develop AI models in one system, and you want to use that model in another system, you need to make sure that the circumstances were adequate and not too different, because then you need to retrain the model locally, but the principles are the same. So it depends on how different the healthcare systems are, and we're currently doing this between Holland and Stockholm, for example, and there is a little bit of tweaking in the model in order to make it as accurate in Stockholm as it was in Holland.
And so you have the operational data, but also there's a rich set of metadata. So you're just talking about different regions. So legislation will change in different regions. I'm sure bodies like the National Institute for Health and Care Excellence have an input. Does all of that have to be configured somehow when you set up a solution?
Yeah, I want to start there, Thomas.
Yes. In short, once again, we look at this as the ACO's own data set. So we are helping the local ACOs with understanding their own data, including cost resources. So of course, national standards and guidelines have an impact, but that's more how you analyze data, not how you set it up. So for example, evidence-based guidelines, yes, they do differ, but they are similar across the Europe or across the European nations. So it depends on what you analyze, depending on what questions you are. Yes, you need to adapt, but it's not a big thing, I have to say. I would like to ask a question to objectivity, take it now or later, but you guys have been running this across the European market, or come across different questions across the European market. What's your experience?
If you take something like diabetes by way of example, and you look at the prevalence among pensioners, where the prevalence is 10 times the prevalence among young people for something like diabetes, and you think about the UK alone with 500,000 undiagnosed cases according to diabetes.org. Healthcare professionals are acutely aware of what lies ahead, and they need methods now to mitigate these trends step by step, instead of landing in a situation where they need a panic button in 5 years from now. I suspect that's what you're seeing in Boston and Sweden as well, that people are trying to sort of turn the ship at a slightly earlier stage instead of panicking right towards the end. Is that what you're seeing?
We're clearly trying to meet demand earlier in the disease and condition progress, and preventive care is key in this perspective, and understanding the patterns to actually see where you can intervene early, and understanding what is happening as early as possible in the trajectories of the disease. That's super important, but you can never do that without seeing your data and analyzing them in ways of prediction and seeing what will come. So yes, we are definitely working in that direction that you're speaking on.
I took that example simply because of the sort of demographics that we see in both North America and also in all of Europe, where a lot of people are getting older, and treating something like diabetes, side effects of diabetes, that's an expensive thing. So if you can model that somehow and so forth, then I think you're probably in a good place to mitigate the effects.
Yeah. Philip, I just wanted to return to the on-premise thing just quickly in terms of just understanding the whole solution. So if I said, again, I'm very interested, but I have no sort of on-premise capability, I can't move outside of the walls, would you be able to advise me? Would you be able to help me understand? Because sometimes big data, it takes a lot of compute power, and that's all the cost to me. So can you help me understand the full investment and how I would have to set up an infrastructure to be able to support the solution you have?
Yeah, absolutely. I think all that is feasible. However, I would defer to Thomas on this question, because that is his area of expertise in all of this. Thomas?
Yes, no, we would be more than happy to do that. Yes, of course. And it's to size the infrastructure is not that challenging. The big question is almost always data quality. What data do you have, and how do we handle the data? So if we will do it on-prem or in the cloud, if we can choose, absolutely the cloud. But as Philip said, some regions prefer on-prem. But the infrastructure and the platform is exciting. But once again, the real stuff is data and data quality.
Mm-hmm. And Thomas, if for some reason I don't quite have the data I need,
yeah,
can you help me find it if that's possible? Or is that just, sorry, I can't go any farther? Or how do I get to a position where I can benefit?
Well, one important thing, and that also goes for Region Halland, they did not do everything at once. So they did not download all the data day one, and day two they were up and running. You do it quite often step by step. So we think it's a good advice to start, well, not start small necessarily, but start with what you have. And if you have one big question or one critical question, one pain point, let's start with that one and make sure that that works. And then we take the next one and the next one. So yes, absolutely. A step-by-step approach is almost advisable.
You know, one other thought. I'm sorry to interrupt. I was just going to say on that point about, you know, the data and sort of how do you begin, just by you know, by way of sort of illustration. You know, when we first started our work together and our collaboration with Region Holland, they had something like 400 different IT systems that were working together in a kind of a sort of a best of breed, you know, kind of hybrid solution, right? So they had all different sorts of systems. So data was all over the place, and they had already started down the path of developing a data lake. So they had done some integration work with integrating some of those data sources, but not all of them. And so I think that my sense is that, you know, in healthcare systems that, you know, everybody is, you know, at a different, you know, their own, you know, sort of stage of evolution with this, right? You know, some have already implemented, you know, bigger, you know, kind of vertically integrated EHR systems that, you know, have done a lot of that integration work. Others have not, and, you know, so people are at different places. And I think that you know, we can absolutely help with that kind of integration journey. But I think, as Thomas says, you know, the important thing is to try to just get started with the core, you know, data sets, and then you work on that over time.
And if I have, so my rule is generally, not always, to never throw data away. So if I have incomplete data, can you help me to fill in the gaps? Can we maybe interpolate some stuff, extrapolate some things, or is that just a step too far? How do we know how to balance that?
Depends so much on what data it is, but you know, the general principle: the more data you have, the better off you are. And let's include and input everything, and then we firstly quite often clean the data, because the quality of the data, once again, is an important factor. Then if we have empty rows, empty data set, depends on what it is. But yes, of course, you can extrapolate. But once you start to extrapolate, you really need to know what you're doing, because you're entering to what we in Sweden send the thin ice area. It's easy to go wrong there. You know?
I know sometimes, Thomas, we've had a beautiful straight line that turns into a hockey stick as soon as we glance away, and that's one of the dangers of extrapolation. Interpolation's a little safer sometimes, but extrapolation you have to be really careful of.
It's often I wouldn't say easier, but one can think about comparing your data with other regions or other ACOs, and that I would guess is a better approach, at least to start with.
I think, Marcus, you talked about the kind of value effort mapping, so that you get your priorities straight at the beginning, so you know where to focus. And Philip mentioned knowing when to start. And an important thing, I think, is also knowing when to stop, or perhaps knowing when to change your perspective or direction a little. How does that work? Is that part of a consultancy? Is that part of system guidance? Is that part of the offering that you have? How do I know the best possible benefit or the best possible direction to go in?
Want to go on that, Philip?
Or Philip?
So you know, the question is, you know, how do you set priorities? How do you know when to move on to the next priorities? I think is a really important question. Absolutely, for any kind of, organizational optimization work, which is, I think a lot of what we're talking about here in healthcare. And and the way I guess the way that we've tried to approach all of this is to bring a quantitative framework to thinking about these questions, so that can kind of enable a way of prioritizing things that is easy to define and easy, hopefully, to communicate to people, because it's more quantitative. So on the setting of priorities, I think one of the ways that we think about that is in terms of identifying variability, right? So, in an ideal world, similar patients with similar problems would receive similar care, and they would have similar outcomes and have similar costs, right? That could be one way of thinking about what does the ideal state look like. And then if there's deviation from that, right? If you have similar people with similar problems who get different kinds of care, you could say, well, why is that, and how do we try to optimize that? So I think that kind of conceptual approach is a way to think about, sort of defining, opportunities for improvement, and then you can quantify those and you can prioritize them. In terms of knowing, when to stop, or when have we succeeded, when have we reached the goal that we're trying to get to, I think, there's a way to kind of think about that at a micro level and then also at a macro level, right? So at the micro level, if we think about, what do healthcare systems do and what are they trying to do better? We're trying to provide care for populations of patients across the healthcare system. And so we can think about that as a whole series of different processes, care delivery processes. And in the platform, this is kind of the core of how we've structured the analytic engine in the tools in the platform is to really allow planners and managers and care people responsible to be able to model population-oriented care processes, right? To define a process in terms of what is the population of patients that's touched by this process, what is the care delivery process itself, and what is all of the care encounters and the utilization that is a part of that process. What are the outcomes that matter? If we're talking about congestive heart failure patients, there's a set of agreed upon clinical outcome measures that define what does optimal care look like. So we can build on that, we can leverage that, and then we can talk about, well, what's the actual cost of delivering that care? Because that's a core part of what the system does. So we can then define a current state, right? This is how things are today. And then if we want to change that process, we can model what the change is. We can come up with effect, kind of metrics to just describe what do we expect based on the literature or expert opinion, what kind of impacts can we expect to see. And then we can model what does the future state look like. And we can do a return on investment analysis, and then all of this we can quantify, and we can say, so we have outcome measures, we have cost descriptors, and I think those are really the key things. If we talk about the world of value, right, that really means in our world it's outcomes, and what does it cost to produce those outcomes, and so at a micro level, I think that's the way we can define success criteria. Right, and ideally we want to do that up front before we pull the trigger and implement something in a healthcare system. But once you've done that, right, then it's relatively straightforward to be able to monitor those outcomes, the clinical outcomes and the cost parameters that you've defined ahead of time. And you set targets for those, and when you achieve those, I think that's how you can measure success in a very quantitative and granular way. For every individual process, and then you roll that up to the whole healthcare system level, and you can talk about, well, what's the net savings, what's the net kind of financial benefit that you've had, and then clinically you can look at all of the different clinical measures. Marcus shared some aggregate measures that are used in Sweden, and many countries have those, but I think this is how we are trying to think about, kind of measuring success and driving success in healthcare system optimization.
That's a really good answer. And I know we're running up on time, but I've just got one question here that talks about deploying this on several conditions or several different scenarios, and which was the one that was more useful or more accurate? How did you predict values? And also, just to add, I'd like to say, if your outcomes aren't quite, or if my outcomes aren't quite matching the predictions, what options do I have? Do I stop? Can I reconfigure? What would happen?
Take that, Marcus, or?
I think one important aspect of information-driven care, which is what we're talking about, is the monitoring of the development of your healthcare system. So once you decide based on a return on investment or a simulation or a prediction based on AI, you continuously need capabilities to monitor what actually happens, to know that the risk of deviating from the preferred route is minimized, and that you can act immediately if you identify something that is not in line with what you wished for, based on the same data that you started your analytics on, because if not, you cannot find the gaps. So I think the monitoring side is super important from clinical perspective, financial perspective, HR perspective, all at once. So that's like my condensed answer.
Thank you. And I think just the final comment on that, Peter, so it is, Peter Drucker, I think, said that, you can't improve what you can't measure, and it's really important. Are there any qualitative measures here? Is there room for any qualitative measures, or is it all quantitative?
Well, I can go for that one as well. Everything that can be put into data is in there. So and quantitative aspects of care are important and abundant, and you need and for you to use them, they need to be put in the platform in described as data, but they're still quantitative variables. And from I have a research background as well, and if you do that, you're used to dealing with both quantitative and qualitative data. That's nothing new to healthcare, but you need to be able to put them where you can describe them in a transparent way. That's the most important thing.
Thank you.
I think that's huge, and I think it's an amazing situation that we head into now as we go towards the turn of this year into next year, and we're sort of actually heading from here to the year 2030, and that is not such a long distance. If you think about how much development has actually occurred between 2010 and 2020, a lot has happened. But if you look at the demographic challenges we face, I think doing things step by step now and acting now is critical, and that's what we're seeing from objectivity standpoint. From objectivity standpoint, we're seeing a lot of interest in these methods, using this platform, both well, in all of our major markets throughout Central Europe and so forth. So I really look forward to taking this and learning more and more together with you guys. I think what you've done in Boston is awesome. What you've done in Sweden is incredible, and there's a lot of interest. I think we can actually make the world a better place by doing these things. It's a small statement, but hey, I think we should shoot for that one, don't you think?
Absolutely.
So in that case, I'd love to thank you all very much for taking the time for this. Thomas, Philip, Marcus, Matthew, and it's been an incredible thing, and I really look forward to hearing more from everyone about this as we go forward. Okay, thank you again.
Thank you.
Thank you.
Thank you all.